tell people, I've got good news and bad news for you. Which would you like first? And their response is usually, they'll give me the bad news. And I'm like, okay, the bad news is I don't have anything that I can give you to cure you of this. It's a viral illness. There are no antibiotics that are going to make this better. And if I gave them to you, they could cause you some pretty significant side effects. But the good news is that this is going to follow the typical course that your other upper respiratory tract infections going into a lower respiratory tract bronchitis have followed, and that we do have some symptomatic management that we can do.
On today's episode, listen in as our expert panel digs into identifying and treating acute bronchitis and community-acquired pneumonia. They'll discuss when antibiotics are appropriate, which antibiotics to use, and other management tips. Our panel for this conversation includes Dr. Stephen Carrick from the USC School of Medicine, Greenville, Dr. Andrea Darby-Stewart from the University of Arizona College of Medicine, Phoenix, and Dr. Craig Williams from the Oregon Health and Science University.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. None of the speakers have anything to disclose.
We often refer to acute bronchitis as a chest cold, and this is where the inflammation and mucus in larger airways of the lungs often will see bronchitis in addition to URI symptoms, or symptoms may shift and bronchitis may follow an upper respiratory infection. Acute bronchitis is usually viral. Rarely is there a bacterial cause. The lung inflammation and mucus can lead to coughing with or without sputum or mucus, chest soreness, headache, fatigue, and these symptoms can last for weeks. They can also overlap with other health conditions. And Stephen, can you comment on other respiratory illnesses we'd want to rule out for patients with bronchitis symptoms?
Oh yeah, during viral season, flu, COVID being the most common one. Pertussis still, it's out there. We hope that all of our patients are getting their vaccines, but we know there is some hesitancy with receiving certain vaccines and boosters in some of our populations. So it's certainly something to keep in the back of your mind that requires some additional testing to make sure that clinics have access to. But flu, COVID, RSV probably being the big ones to think about as viral pathogens. And then we think about other forms of potential pneumonia that could be causing patients ongoing symptoms, especially if they have fever, really productive, maybe bloody, purulent cough, really bad shortness of breath. Maybe they're elderly, have other comorbidities like heart failure, COPD, diabetes, in which case we really want to be mindful of potentially a community-acquired pneumonia, whether it's something like strep pneumo or even some of our more atypical pathogens like mycoplasma, but being very mindful of those things. Fortunately, we have some rapid tests for things like flu, COVID that can give us those answers pretty quickly, but definitely using a lot more of our clinical gestalt and whatever labs that we have available to us, whether it's inflammatory markers like procalcitonin, CRP, ESR, chest x-rays, CBC, stuff like that, just to help guide us through those patients that may have something more complex than a viral pathogen or a viral bronchitis, but maybe something more significant or severe like a community-acquired pneumonia.
Thank you. That's a great overview. So Craig, can you comment on when should we refer folks to a prescriber? What would you tell, say, for example, a pharmacist to look for and have patients follow up right away?
Yeah, and it does kind of depend a little bit on the setting. So if you're in an ambulatory setting and have access to things like chart notes and labs and can know a bit more about the patient, it does make it a little bit easier. In the community setting where you might not have access to those or don't know baseline comorbidities a patient may have, it does make it a bit tougher. But what I'm really looking for are signs of, is this progressing to pneumonia? And then even among pneumonia, we have kind of mild, moderate, and severe categories. But what I'm worried about is pneumonia for a patient, which, for us means the infection is spread from just the air tubes into the actual lung parenchyma. And that can become severe fairly quickly. And pneumonia in our older at-risk adults has an incidence certainly of mortality as well as morbidity. So what I'm looking for is signs of pneumonia are against a bigger infection. So we think about our SIR signs. So if I know their temperature, if they're febrile, that's pretty uncommon for bronchitis, much more common in pneumonia. If I have access to their labs in the last 48 hours, if you have a white count above 10, that's much more likely pneumonia. That's very rarely bronchitis. And part of it is too just kind of a bit of a gut check. If the patient's there in your setting, sick pneumonia patients look really bad. And otherwise healthy folks with bronchitis, they have a cough and maybe a bit of sputum, but they don't look that sick. So, for our experienced clinicians in all settings, you can somewhat trust your gut. But I'm looking for objective signs that this patient really looks ill. And for pneumonia, again, the big ones for us are fever, white count if I have it, and then if it's progressing, a rapid respiratory rate and a low blood pressure. But that's not going to be available in all settings.
Great, thank you. Since acute bronchitis is usually viral, antibiotics won't help. This may be a good time to use that viral prescription pad to reinforce that antibiotics won't help. Andrea, can you share how you talk to your patients about lower respiratory tract infections like acute bronchitis that are likely viral?
This is one of my actually favorite conversations to have with people, which I think makes me a little bit of an outlier in the medical community. So I tell people, I've got good news and bad news for you. Which would you like first? And their response is usually, they'll give me the bad news. And I'm like, okay, the bad news is I don't have anything that I can give you to cure you of this. It's a viral illness. There are no antibiotics that are going to make this better. And if I gave them to you, they could cause you some pretty significant side effects. But the good news is that this is going to follow the typical course that your other upper respiratory tract infections going into a lower respiratory tract bronchitis have followed, and that we do have some symptomatic management that we can do. And for that, I want you to rest. I want you to treat yourself to some chicken noodle soup or whatever has been appropriate for you and is the thing that in your family has made everybody feel better when they're feeling poorly. Increase your fluids. You can use some nasal saline, use hot showers, cool mists. All of these things can really help you with your respiratory symptoms, and it will get better. But the cough can last for several weeks, and so it's important for us to make sure that you're taking good care of yourself.
And Stephen, how do you counsel a patient with a lingering cough and congestion?
Yeah, one thing I always will reference is that typically during viral seasons in clinics, we just see so much of this. And I think telling patients that we're seeing a lot of these kind of symptoms going out in the community right now. You're not alone in this. Your symptoms seem pretty typical. And here's why I think that this is likely a viral pathogen. And kind of going through those lists, maybe they have a lack of, or maybe a very low grade fever. Their cough is minimally productive. They have maybe some mild congestion. They're presenting with kind of the typical symptoms, maybe a little bit of fatigue, myalgias, and then saying, I'm reassured that you don't have a pneumonia because of these things. Maybe they're not excessively short of breath, or again, that mucopurulent cough or high fevers. And I anticipate these symptoms to improve with a little bit of time, but sometimes it takes about 7 to 10 days. The cough can be a lingering thing. It may take a week or two to go away, but I think we can really manage these symptoms, and I hope that we can get you better a little bit quicker. And then also counseling them on, here are the red flag symptoms, here are the things I want you to look out for. If you're not getting better in this period of time, or if these symptoms evolve or change in any which way, that's the time that we need to see in person so we can reevaluate, consider if you need additional testing. And then providing whether recommendations on medications, whether they be over the counter, prescription, but just those management strategies to help them navigate those symptoms so that they can feel a little bit better. I mean, it's no fun being sick. And so we want to get people back to being able to enjoy their lives as quick as we can, but knowing that, these are just hopefully this is just a mild viral pathogen that we can get you feeling better a little bit quicker with, some common remedies, anti-inflammatories, Tylenol, fluids, rest, hydration, all that stuff.
Thank you. You can review the pros and cons of non-drug measures and OTC options in our chart, Managing Cough and Cold Symptoms, on our website. And Steve, I'll turn it back over to you.
Thanks, Sarah. And I'm glad we mentioned pneumonia earlier when differentiating bronchitis, because community-acquired pneumonia, or CAP, is our next topic. And you'll see that treatment here is more extensive, which we will review for both adults and kids. So I like to think of pneumonia as coming in all sorts of shapes and sizes. Sometimes patients can acquire pneumonia in the hospital, but here we're focusing on when it's only acquired in the community. CAP is defined as pneumonia developing in patients who were not admitted to a hospital within 48 hours before a diagnosis. And CAP can be caused by many different types of organisms. Today, we'll only focus on bacterial CAP. The most common culprits include bacteria like Strep pneumoniae, Haemophilus influenzae, and even atypical bugs like Mycoplasma. As with many infections, we're going to see that comorbidities like diabetes and renal disease can increase the chance of having resistant versions of all these bugs, and that will affect how we treat them. So when deciding how to treat bacterial cap, we need to divide our patients into two separate groups: those who get standard treatment, which are healthy patients, and those who need broader spectrum coverage due to resistant risks. So patients at risk for resistance are those with comorbid conditions like chronic heart or lung disease, diabetes, and even cancer. Others include patients who maybe had prior MRSA or Pseudomonas respiratory infections, since we know those bugs have a lot of resistance factors. Or we have to think about if they needed IV antibiotics in a hospital in the past 90 days, since they may have picked up a resistant bug in that setting as well. So for healthy patients, CAP treatment is relatively simple. Patients can get a high dose of amoxicillin, which is 1 gram TID, or they can get doxycycline, 100 milligrams twice a day. And macrolides like azithromycin or clarithromycin are recommended as an alternative. And the newest CAP guidelines really emphasize this approach of using more amoxicillin for otherwise healthy patients. Stephen, are you using this a lot in your practice since these guidelines came out? Did you see a shift after that?
I personally do. I mean, I'm always a big fan of it, especially if we're treating any bacterial infection, just keep it as simple as we can. Amoxicillin is just kind of for me, the most basic antibiotic, and I think it works really effectively. And I think that's what the guidelines for what suggested, right? Still seeing, I think a good bit of macrolide used for especially presumed pneumonia, but I do worry about kind of the emerging resistance to that antibiotic as well. In my own clinical practice, it's usually amoxicillin. If they have some sort of significant allergy to amoxicillin, doxycycline, those are kind of the two that I stay with. I try to avoid using macrolides just because I just know they're used so often in the community, whether it's for pneumonia or whether for some other respiratory illness. That's my general clinical practice.
Excellent. But if you have a patient that can't tolerate amoxicillin or doxycycline, or perhaps there's even a shortage of these meds, using azithromycin could be an option here. However, it would be important to counsel patients on when to come back for evaluation if those symptoms still don't improve after 2 or 3 days, and have a backup plan for next steps with broader antibiotic coverage to handle possible resistance like we talked about earlier. Now, Andrew, I'm curious, since the CAP guidelines came out in 2019, has your use of macrolides for CAP changed? How often are we even still recommending macrolides for CAP, perhaps even in your practice?
Yeah, I love that question. It absolutely has changed. Again, super easy to, click in your electronic health record and type Z-Pak and hit enter. But in our community, our strep pneumo resistance is well over 25%. And so macrolides are not going to be appropriate for my patients who are non-hospitalized, walking around in the community, but happen to have a community-acquired pneumonia. So I do avoid those. I would direct everybody to take a look at the IDSA guidelines. I think that they did a really nice job with them and are pretty clear about the recommendations for using amoxicillin or doxycycline for the majority of our patients. And those medications at the doses recommended are generally very well tolerated.
Very important points here about resistance. I really like this discussion. And, I'm actually broadcasting out of Iowa right now. And I actually found a recent study that suggests our region had the highest overall resistance, that's something like 54%. So I would be very hesitant to get a macrolide if I came down with CAP right now. All right, switching gears, what if our patient has a comorbidity like diabetes that increases their resistance risks and poor outcome risks? We need to cover for possible resistance up front with a broader antibiotic coverage. So here, we'll cover resistant strep pneumo and Haemophilus influenzae with amoxicillin clavulanate, or a third-generation cephalosporin, like cefpodoxime. But we'll also add a macrolide or doxycycline to that to cover atypicals. Another option here, though, is to give a respiratory fluoroquinolone like levofloxacin as monotherapy. Now, I could see someone looking at this saying, why don't we just give everybody this monotherapy? That's just so darn simple. But that is true. It is simple and convenient, but it could come with some risks. So, for example, fluoroquinolone warnings have grown over the years. Hypo and hyperglycemia and even CNS side effects like altered mental status are important ones to consider, and it may not be dose or duration related. So avoid using fluoroquinolones for elderly patients, those with renal disease, or maybe they're taking insulin or sulfonylurea like glipizide. If used, I'd recommend close glucose monitoring and ensure patients have adequate testing supplies, and educate how to recognize and treat that hypoglycemia. And we know that quinolones have several risks, although they can be rare, things like Achilles tendon rupture, QT prolongation, things like that. I'm curious, Stephen, how much do these factors come up in your decision making when you've used a fluoroquinolone for CAP? And has your use changed with fluoroquinolones over the years?
Yeah, I mean, just because all of the side effects and complications that can arise with fluoroquinolones, I really reserve these as sort of a last line. I mean, unless we are absolutely, this is the antibiotic we have to use. I mean, I just think of the patients that we tend to put these on, they tend to be older, they tend to have some sort of, thing like diabetes. You worry about the risk of tendinopathy for patients, and maybe that affects mobility in some ways. And so I really, again, fluoroquinolones, I just think there's so many potential complications with their use. Yes, they're good antibiotics and they have a place, but I think it's really important to identify the right patient for the right infection to utilize these. And as I said, it's probably more of a lower tier antibiotic for me when I'm dealing with community-acquired pneumonia and most other infections that I will treat with antibiotics. Again, just because of there's so many secondary side effects, black box warnings that could potentially put our patients in dangerous situations.
These are really wonderful antibiotics. And so I'll say when it comes to quinolones, I'm a cautiously aggressive user of quinolones, meaning if I don't need them, we've always somewhat shied away from them for like going back 20 years, more because we knew resistance was going to be a problem. So, 20 years ago, these were kind of our more potent agents we could save and potentially use beta-lactams and macrolides and tetracyclines first. And then quinolones were kind of in our hip pocket as we needed them. And we have seen resistance evolve, unfortunately, but not surprisingly. So we never use them for things where we thought we didn't need them. And that honestly, when the warning first came out from the FDA, we struggle with that a bit like others did. But if you go to the black box warning, it mentions them specifically, not across the board, but in certain conditions. And it mentions the conditions you guys are partly talking about tonight. So sinusitis, otitis, and then urinary tract cystitis. And often those are conditions where we can use something else. So, we kind of took the FDA warning in stride because we already were tending not to use these agents if we had something else we could pick first that we thought would manage that patient. And yeah, for things like otitis and cystitis, I've got better other options. I don't need to risk the resistance of giving that patient a quinolone. But I think where people have gone a bit overboard, and I maybe disagree with some of my colleagues, is if I have a appropriate infection that would benefit from a quinolone, I don't tend to hesitate because of the new warnings. So unfortunately for us, these are very rare adverse effects. And if I have someone with a severe, in this case, pneumonia, or frequently for us on our inpatient practice, a severe urinary tract infection that goes beyond the bladder, these can be wonderful drugs to treat patients. So in the here and now for severe infection, we tend to not be too cowed by the warnings, and we use these where appropriate. But they are for severe infections where we think they're the best drug. And for other infections, we're happy to use other first-line agents, which are safer. These side effects, while rare, are real, and we didn't really appreciate that until we started getting a lot of post-marketing surveillance of these drugs. So these are not adverse effects that come out in smaller randomized trials of 200 or 300 people, but they clearly happen. And we actually know, going back into the FDA approval databases, in the animal studies, some of these things came out. If you give super high doses of quinolones to animals, you can see some of these observed side effects. So there's underlying mechanistic reasons to believe that they're true. But again, in a severe infection where they're the right drug, we don't hesitate to use them despite these warnings.
Yeah, great example of weighing benefits versus risks. Love that. We can tailor therapy with these risks in mind. First, we could recommend considering fluoroquinolone monotherapy when patients can't take a beta-lactam with a macrolide or doxycycline, for example, if there's a severe beta-lactam allergy. Or they could be considered for patients who are likely to have maybe very notable non-adherence with those combo options, but have a low risk of side effects from those quinolones. It would also be good to check for cardiovascular disease history due to that vessel issue that we may see, but also arrhythmias, which can frankly also apply to macrolides. And as always, we should be considering medication interactions since comorbidities do add up in terms of patients needing to take multiple medications that could pose a risk for that. One example I can think of I've encountered in my practice is levofloxacin with warfarin and how that can increase the INR and risk for bleeding. So newer CAP antibiotics like omadacycline and lofamulin have made the news when they came onto the market a couple years ago, but we still aren't completely sure what their place in therapy is, and they can be quite costly. For example, a 3-day supply of omadacycline is over $1,500. So it would seem appropriate to avoid routinely using these newer meds at this time, but I'm curious to our panelists, have you used these newer CAP agents in practice? And if so, can you share any experiences or pros and cons you can think of?
Yeah, no, I definitely share that they should not be routinely used and saved. In fact, I believe that so much I have not used these yet in practice. So yeah, at our academic medical center, these uses will certainly be in the context of certain protocols for where they'd be appropriate. But yeah, newer agents definitely save for where we don't have alternatives. And yeah, I do not yet have any personal experience with either one. So I'm practicing what I preach and saving them for special circumstances.
I honestly have not seen them used yet. I don't even think I've seen them used, at least in our community, by our infectious disease colleagues. So I don't have a whole lot of knowledge, firsthand use of them, unfortunately. But yeah, and so I guess that's where it is. I just don't see, and I even haven't seen our infectious disease colleagues use them yet.
Yeah, they definitely seem like they need to get more data and find their place in therapy. Also think about antibiotics the patient has taken recently. Recent exposure may make bacteria resistant, and using the same antibiotic again right away may be less likely to help. So using a different class can prevent this. For example, let's say a patient recently completed a course of amoxiclav for sinusitis. Instead of using that again, we can give cefpodoxime plus doxycycline instead of that same approach. With all that in mind, I briefly want to point out differences with adult CAP treatment to what we do for kids. I am a pediatric pharmacist after all. So keep in mind, CAP in kids under 5 is usually caused by viruses, so antibiotics typically aren't helpful. Strep pneumoniae and Haemophilus influenzae are still the most common bugs when we do have bacterial CAP in kids, but we recently saw a surge in mycoplasma cases in 2024, with kids under 17 having the highest increases. So unlike adults, instead of dividing treatment by comorbidities or no comorbidities, in kids, it's actually divided by whether we think that the pneumonia is bacterial, atypical, or even both. We'll use high-dose amoxicillin first line or amoxicillin clavulanate second line if we think it's presumed bacterial CAP without a concern for atypicals like mycoplasma. And usually this decision about atypicals is based on the prescriber's impression. So think about the same dosing and administration principles of high-dose amoxicillin and amoxiclav that we talked about earlier with otitis. Now, if a prescriber thinks the patient has CAP caused by a bug like mycoplasma, then we can add on a macrolide or doxycycline here, or potentially use them solo, depending. So for Andrea, my question for you is, what do you look for when diagnosing a patient with atypical pneumonia? Because most pharmacists may not be able to see that from our perspective.
Yeah, absolutely. So, the majority of our kids that are, under, kind of elementary school kids, when they come in with community-acquired pneumonia, actually have an atypical pneumonia. And unfortunately, we experienced one heck of a mycoplasma season this most recent fall. So, majority of the listeners may be very familiar with what an atypical pneumonia looks like in a kid with this presentation, but they still have the high fevers. They still feel lousy. They're still coughing. If you get a chest x-ray, you're not going to see that lobar component that you'll typically see with a bacterial community acquired pneumonia. And these kids generally respond very well to azithromycin. So that has been my go-to for kids who we think have an atypical pneumonia. For adults, it's a little trickier because we have a larger spectrum of bacteria that may be likely to cause this. And obviously, we can't forget to rule out things like COVID and RSV and influenza as well in the peak of our viral season right now. But for adults, if I'm not seeing a lobar component and I am concerned about an atypical, in my practice, I would use doxycycline because I don't want to miss that strep pneumo in an adult that I know may be resistant to azithromycin in my community.
Yes, you can hit two birds with one stone. That's
Exactly.
perfect. And I want to take a moment just to go back to doxycycline. Many of us know doxycycline gets a bad rap with kids. Initially, doxycycline was never used in kids under 8 years old due to concerns about teeth staining. And most of that was actually due to data from older tetracyclines that did indeed lead to teeth issues. But this isn't really supported by newer data regarding short courses of doxycycline. So in fact, the AAP said in the 2010s that kids of any age can safely use doxycycline for up to 21 days. So this could be an option if a child can't use azithromycin, for example, due to an allergy or a product shortage. But keep in mind, some doxycycline oral suspensions may need prior authorizations due to their higher cost. For example, one 60 ml version, that bottle costs about $130, so not exactly inexpensive. I'm curious for our panelists, have you been using more doxycycline in children since the AAP changed their recommendations, and how do you communicate these risks with parents in that case?
Yeah, no, it's a great question. And working with family medicine, we definitely have pediatrics as part of our practice setting. And so it's been a slow evolution, but it is fair to say we should not paint the tetracycline warnings across all the drugs. And it was reassuring to a lot of us that doxycycline is potentially available as an alternative. But say there's still a lot of inertia against this and a lot of concerns. And if we do have alternatives, I'm not seeing a lot of change yet in our practice patterns, but I think the AAP was right in that change. And it's nice to have this alternative, but I think it is going to be a slow evolution. So I'm not seeing a lot yet, but we know that it is an option for kids now. And it is nice. It's very nice to have that in the guideline.
Yeah, and being a pediatric pharmacist myself, I'm really excited to kind of see what the next guidelines will say. So I'm kind of waiting for that.
Am I using doxycycline a whole lot? Man, probably not. Mainly treating pneumonias with whether it's amoxicillin or a cephalosporin usually is most of the antibiotic prescribing that we'll utilize for this. Have I used doxycycline a few times? Yeah, and it will kind of let them know that, hey, you may see that there may have been some concerns about teeth staining. That's something, especially if using for a short course at lower doses, probably not going to be a big risk. So I think it'd be a fine antibiotic to use for this, especially when you think about, how you want to worry about rates of resistance to things like azithromycin. And so it has a place. Do I use it a whole lot? Probably not, but I think it's becoming more common to be used for those patients that it's indicated for.
So, Craig, can you comment on the role of steroids for CAP? This is actually a common question I've gotten in my practice. I'm curious about your thoughts.
Yeah, it is. It's a great question. And actually, it really kind of got accelerated or highlighted during and coming out of COVID. It's become a complex question, but it's easy on the ambulatory side when I get this question from my ambulatory colleagues, a definite no. And it's a maybe yes for severe inpatients. And it's a fun debate to have when it comes up in the hospital setting, but generally not outside of the ICU setting. We're generally not using steroids, even in the hospital.
Yeah, it's always been kind of a pros and cons discussion on a case-by-case basis. So based on all this, how long should we be treating outpatient CAP? I'll let you go first, Stephen.
Usually say about 5 days. I know there's been some studies out that even said shorter for hospitalized patients, like as low as 3 days, I think. So 5 tends to be about where I have settled and probably my common practice right now. Maybe a little bit longer if they maybe 7 days, or a little bit longer if, say, they have significant comorbidities, older patients, treatment failure. And so those are the kind of the cases where I'll see that. But for most outpatient cases of community-acquired pneumonia, let's say I got 5 days, close follow-up. I think close follow-up is important with these patients just to make sure they're doing better. But the 5-day duration is usually where I start with.
I'd say for the last decade, we've been doing what we can to kind of shorten durations with the one qualification that if you improve in the time course I expect you to improve in. So, the lungs are nicely perfused, and if the antibiotic gets there and does what it should do, we generally start seeing patients feel a bit better even on day 2, but certainly by day 3. So we're going to give you kind of 48 hours to hopefully start looking better. And if you start looking better in that 48-hour time period, then we've been kind of a 5-day duration organization for quite a while. And the guidelines kind of endorse that. Maybe even shorter than that is effective. Once you seem to be heading in the right direction and you've got the right antibiotic, or potentially, as we admit to ourselves, the patient's getting better despite our antibiotic. Once they're on the mend, it seems to be you can really shorten up the duration compared to what we used to do. So we train our residents and what we teach our students is no one should be going longer than 10 days unless you've got a good reason for it. And generally 5 days is your target. The exception would be if I'm not getting better in that window, and we definitely have that come up. So patients that have really severe underlying lung disease, patients with obstructions, underlying lung cancer, and there can be times where it almost becomes like treating abscess in the lungs rather than attritional pneumonia. So if we're not seeing that nice time course of improvement, we're going to need to extend. And that generally, if you're not looking better within 72 hours, I'm not going to be stopping your therapy at 5 days. But again, a good clinical response within 48 hours, that 5 days is still our target. And maybe in the future, it'll be even shorter. We'll see how the studies evolve.
Yeah, with the trends and how they're going. And this is such a low-hanging fruit in terms of stewardship for pharmacists. This is one of the first things I look at a script for really any antibiotic, and we can really take some great actions to curb excessive antibiotic use. Very important points there. Thank you. And any final thoughts from the group before we move on?
At least in my conversations with patients this year and maybe a little bit of last year, I'm seeing less resistance with just naming it as a viral illness. And the conversations regarding antibiotics have not been as confrontational, I guess I should say. So I don't know if there's a lot of information that's going around, or if people with COVID or just like have kind of accepted just the nature of viruses, given that's what we were, was just in the front of our mind for any illness for the long period of time. So hopeful it represents some maybe cultural shift. I know there's probably I still get a lot of patients that are like, I need my Z-Pak, I need my amoxicillin, I need this or that. But at least this viral season, I feel as if I've had to do less counseling and more patients on antibiotic stewardship, and more patients have been pretty receptive to watchful waiting, delayed antibiotics if needed, utilization of prescription medications to handle symptoms. So for me, that's been a good thing.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit.